us today for the Press Club Headliners event or our virtual Newsmaker event. It's great to have everybody here. Hope to be back in person. I know that we've had a couple of these in person, a couple of virtual, so we're kind of seeing what works for everybody. But hopefully, sometime in 2022, we'll have everything in person because I think everybody would enjoy that. But obviously, I have an important issue today and a very important speaker. But first, I want to thank our sponsor, and that's Spectrum News One, for being the main sponsor today and for being a sponsor of the Press Club and of all of our efforts. So I really want to thank them for their support and for being part of this program. Now I'm going to move right to our speaker, and that's somebody I'm sure everybody knows. He seems to be everywhere. I know I've interviewed him a number of times. He's on the radio, he's on television. Ever since the start of the pandemic, he's really stepped up and become an important source of information really throughout the community for both the business community and really the overall community. And that's Dr. John Raymond, CEO of the Medical College of Wisconsin. I could do a long intro, John, but I think you have more important things to say to us today. So I'm just going to hand it off right to you and just kind of let you update us on what's going on with the pandemic, kind of where we're at, and kind of what you see happening over the next few weeks.
Great, Mark, and thanks so much. I appreciate the kind introduction, and thanks to the Milwaukee Press Club for your interest and your desire to make sure that our public gets good, well-curated information. If I could go to the slide deck, please, Joette. I just want to start by giving a little bit of perspective about the COVID-19 pandemic, which now has claimed 5 million lives across the world, is approaching 750,000 deaths in the US and 8,500 deaths here in Wisconsin. So this continues to be a very significant challenge for all of us, for our health, for the well-being of our families, our communities, our state, and also for our economy. And these are intimately linked, and we've talked about this numerous times in the past. So Joette, if I can go to the next slide, please. I just want to acknowledge Ali Namadi, who is one of our analysts in the Institute for Health and Equity at Medical College of Wisconsin. Certainly, I'm out in front and talking about the pandemic, but I draw on the expertise of about 2,000 faculty members and clinicians who really are in the trenches every day and have deep knowledge about epidemiology, infectious disease, public health, and clinical medicine. If I could go to the next slide, please. I'll just update some Wisconsin numbers. We're very slowly improving, almost grudgingly. The pandemic peaked about a month ago here, this surge, the fourth or fifth surge, depending on how you measure it. But the decline back to pre-surge levels is painfully slow. So we're at over 1,800 cases per day as our current 7-day average. The positivity rate, which we would like to be significantly below 5%, has stubbornly remained between 7 and 9% over the last few months. And the reproductive number, which should be below 1 if the pandemic is decelerating, has been hovering around 1 again for the last 5 to 6 weeks, and it's at 0.98 for the most current 7-day average. Compared to other states, we're lagging a little bit. The surge hit us a little bit later than other parts of the country and is abating a little bit later than it is in other parts of the country. So over the last 14 days, we've had a 26% decrease in our average daily new case counts, and that ranks us as the 37th best state. So in other words, 36 states are having a more rapid decline than we are. Same thing with the 14-day average hospitalizations. They're also trending downward. That's favorable at 18% decline over the last 14 days. And that would rank us as the 32nd best state. In other words, 31 states are a little bit ahead of us. And we're doing okay on vaccinations. We're somewhat in the middle of the pack, ranking 22nd with 58% fully vaccinated, according to the New York Times. If I can go to the next slide, please. Just in terms of average daily deaths, These have remained in the double digits, low double digits for the last several months, and have not actually begun to trend downward yet. And recall that death is the most significantly lagging indicator. So with these other indicators trending favorably, we would expect within the next several weeks that the daily death count will start to go down into the single digits. So our hospitalizations also are going down. We're at 910 hospitalized COVID-19 patients in Wisconsin as of yesterday, according to the Wisconsin Hospital Association. And that is trending favorably, although again, grudgingly, slowly improving. ICU census also is slowly trending favorably at 273 patients. Looking at ICU occupancy, there's actually something interesting and different than the terrible surge that we experienced in November of 2020 that I want to call out. Our ICU occupancy remains well over 90%. It peaked at about 95.5% for this surge, which was about where it peaked for the surge in November, when we actually had double the case counts of COVID-19. Same situation with hospital beds. Our census actually in Wisconsin is higher now than it was even at the peak of the November surge. And I think the main reason for that is that people had delayed and deferred care that they could no longer put off. Also, people's confidence in the safety of the clinical care environment in hospitals and clinics has steadily improved. So we now have had a restoration of clinical care volumes not related to COVID-19 that have gone back up to the pre-pandemic levels, and in some cases have exceeded that. So that challenges us. We have full hospitals to begin with, and even though this surge, again, peaked at about half the number of daily case counts as the one in last November, it still challenged the capacity of our health systems. And I would point out that bed capacity and ICU occupancy don't tell the whole story. We have an exhausted healthcare workforce that have been working very, very hard for over the last 18 months. And I think that the human factor, our ability to staff for people to be fresh and at their best, really is our limiting factor for dealing with COVID-19 and non-COVID-19 illnesses right now. Just on the bottom right, the ICU census trend is the same here in Southeastern Wisconsin. That's the HERC-7 region. And we may be just a little bit more favorable than the rest of the state. Recall that this surge of the Delta wave hit us a little bit earlier here in Milwaukee than it did in the rest of the state. So you would expect the decline to come a little bit sooner. Next slide, please. All right, this is a picture that I really like to show that graphically demonstrates the burden of disease in Wisconsin in each of our 72 counties over the last year. So starting at the left, you see the case counts for each county in Wisconsin last November. And you can see that we had most of our counties were at critically high levels of COVID-19, with the remaining handful of counties at very high levels. When we started to vaccinate people January through March, we had a significant decrease in the case burdens in all of our counties. And you can see that we had a few counties that had medium levels, with most being high, but no very high or critically high. Going to the third picture from the left, in June, right before the Delta wave hit us, even right up until the beginning of July, we saw continuing improvements in our case burdens, with about a third of our counties with low or medium levels of case burdens. And unfortunately, that turned around very quickly in July and August, with accelerating trajectory of the pandemic and high case burdens. So on the right, these are the latest data available that were released last Wednesday at 3:30. We'll have new data tomorrow at 3:30. But you can see that we have not reached the same level of critically high case burdens that we did last November. But we still have a significant number of counties, 4 that are critically high, 65 very high, shown in dark blue, and a couple that are high. So even though the pandemic is trending in the right direction, we still have a very significant risk of community transmission from incidental contact with others because of this high case burden. So this is something important. If you went back 5 weeks ago, we actually had a significant number of counties that had a critically high case burden, and that would have been about 21 counties. So we're clearly moving in the right direction right now. Next slide, please. So just to summarize some trends in the US, the fourth or fifth wave, depending on your community, of COVID-19 is decreasing clearly throughout the US, with a few notable exceptions. Colorado and Alaska are still struggling with hospital capacity and case burdens that don't seem to be going down. But on average, the daily case counts in the US have declined to under 75,000, and they had peaked at over 100,000 per day just about a month ago. And these have decreased by 13% over the last 14 days. Hospitalizations are decreasing now, with about 50,000 hospitalized patients in the US, again, after peaking at 100,000. And hospitalizations also decreased by 17% over the last 2 weeks. Deaths are going down, but very slowly. We're still at about 1,400 deaths per day in the US attributed to COVID-19. And Wisconsin, as I mentioned, still has a very high case burden, on average 525 per 100,000 cases or patients, population over the last 2 weeks. And that seems to be decreasing, but slowly. And as I mentioned, Wisconsin hospitals are full, and I explained that this is a combination of our second highest surge of COVID-19 with a pent-up demand for non-COVID care. Next slide, please. The FDA and the CDC have been very busy over the last few months, and I hope that one of the takeaway messages is that our regulatory bodies have taken their responsibility to keep us safe and to go through a very rigorous scientific and clinical review process very seriously. But they have worked hard, and you can see what's happened over the last 6 months. FDA granted emergency use authorization for the Pfizer vaccine for kids 12 to 15 years old. They gave full approval for the COVID-19 vaccine for people 16 and older. The FDA expanded the emergency use authorization for the mRNA vaccines, Pfizer and Moderna, to include a third dose for severely immunocompromised patients. That was in August. Then they granted full approval for the COVID vaccine. And then in September, they expanded the booster dose to people 65 and older, people 18 to 64 years old at risk because of health conditions, occupational or institutional exposure. And then in October, the FDA Advisory Committee recommended authorization of booster shots for J&J and Moderna COVID-19 vaccines. So all three of our vaccines are eligible for booster shots. And that is in recognition that although the immunity that we have from vaccination, and to a lesser extent from previous infection, gives pretty good protection from the things that matter, including severe disease, hospitalization, and death, that the immune response is waning. And so it is suggested that people that are eligible and at risk can get a booster shot. What was interesting also was that the CDC authorized a heterologous or mix and match COVID-19 vaccine booster approach. And in particular, I think the recommendation seems to be the strongest for the J&J vaccine, which is a one shot. And there's clear data that antibody responses are elevated more significantly if the people that received a J&J shot get either a Pfizer or a Moderna booster rather than a J&J. Next slide, please. And to get to what Mark said, what can we expect in the near future? There will be a decision about the emergency use authorization of the Pfizer vaccine for kids 5 to 11 years old very soon. The committee is meeting right now. You can actually live stream it. And their recommendation is expected to happen this afternoon between 3:15 and 4 o'clock Central Time. And I just want to refresh everyone's memory. There's a multi-step process for authorizing the vaccines. The FDA has an external advisory committee of independent experts that makes recommendation. The FDA director then makes an authorization, and that happened for the Pfizer vaccine for kids 5 to 11 years old last week. Then the CDC has a similar advisory committee that meets. They make a recommendation to the CDC director, who then defines who is eligible for the authorization. And then finally, each state Department of Health Services has to weigh in. So this is all going to happen very quickly, and I think positively this week. In anticipation of that, the federal government has somewhere between 10 and 20 million doses of the Pfizer vaccine ready for distribution to children. I want to make sure everyone knows safety is foremost. So the packaging and the labeling and even the color of the syringes for the kids' doses, which are reduced doses, they're 10 micrograms instead of 30, are different than the adult dose. So for quality control, to make sure that the kids get the right dose. So we should hear about that today. And to put it in context, there's somewhere between 24 and 28 million US kids in that age group that could be eligible. There will be a decision about the full approval for the Moderna COVID-19 vaccine for people 18 and older. There will be a decision about emergency use authorization of the Moderna vaccine for kids 12 to 17, and then for kids 5 to 11, but I do not expect that to happen in November. The FDA has requested more information about heart inflammation with the Moderna vaccine before they're going to act. And also some interesting things that may not have been discussed enough. AstraZeneca has a monoclonal antibody treatment that is very promising and may actually give better protection than either the Lilly or Regeneron product. I expect emergency use authorization to happen within the next few weeks. There will be a decision about an oral medication that seems to be useful for helping with mild symptomatic COVID-19 disease if taken early. It's called, the pill's called molnupiravir. Again, I expect that will receive emergency use authorization perhaps by the end of November. And there are 10 million doses that are ready to be distributed in the US. This is less expensive than the monoclonal antibody treatment. It gives about a 50% protection from hospitalization and death. And it's still pretty expensive. It's about $700 per course. So if we could find something less expensive, that would be even better. There are a couple of other similar pills in the pipeline from Pfizer and Roche. And a couple things, again, that we haven't really talked about. I expect emergency use authorization for another vaccine from Novavax to happen either by the end of this calendar year or the first quarter of 2022. Now, you may say we don't really need another vaccine. We've got plenty of supply in the US, and that would be correct. But this uses a different technology where it introduces a synthetically produced antigen rather than asking the body to produce the antigen. So there may be advantage for Novavax in certain situations. And I do expect there to be more research about the difference between natural and vaccine-induced immunity. Next slide, please. And these are some of the data sources we use. And with that, I'll turn it back over to Mark and say thank you.
Good. Well, thank you. That was very informative. You know, a lot of really important information. I'm sure it's going to prompt lots of questions from our journalists. I'd ask our audience too that if they have questions, I'm going to leave some time at the end for those. If you could put those in the chat, I will see those, and then I will ask those of Dr. Raymond. So I'm going to go ahead and get started with our panel of journalists. We have three great journalists here today who are very active in the market, who have written about this issue, who have broadcast about this issue. So I want to introduce them. Let's start first with Uba Ali from KMJ4, Drake Bentley from the Milwaukee Sentinel, and then our own Rich Kirchen from the Milwaukee Business Journal. So I'm going to start with you, Uba, and I'm going to let you have the first question.
Good afternoon. Thank you for joining Dr. Raymond. My first question really is centered around the hot topic of today and CDC advisors meeting to discuss if a vaccine will be approved for children 5 and older. The hesitancy is still very relevant in our community and throughout the world. But for some parents that have already gotten the COVID vaccine, they're hesitant about getting their children vaccinated, especially the newer age group, if it does become approved. What do you say to those parents on to ease their mind?
Thank you. That's a very important question, Uba. And first of all, let me just acknowledge that vaccinating our children is a deeply personal choice and one that parents take very seriously. And I also want to acknowledge that the risk from COVID-19 to kids is not as severe as it is for adults and the elderly. On the other hand, COVID-19 is a serious disease. It can cause multi-system inflammatory syndrome in children, which is treatable, but still potentially very significant. It has killed something like 800 children in the US under the age of 18, I think 172 under the age of 11. So even though unusual, there can be deaths. And kids can also get long COVID syndrome. So they can have difficulty concentrating, they can be fatigued, can have chest pain. Again, not as frequently as in adults, which it's been estimated a third can have long COVID. But kids anywhere between 5 and 15% can have these persistent symptoms that can make it difficult for them to function, to progress in school. You know, the other consideration, again, is more along the lines of what's best for society. Children interact with susceptible older individuals. And there is a risk that even though the kids may have mild disease, they can pass it along to somebody that can be significantly impacted in a negative way. And then finally, if we really want to have some semblance of resumption of normal life, the more people that we have that are vaccinated, the quicker we're going to get there. So those are the considerations that a parent should try to balance.
Drake.
I think that's a question. I'll send it over to Drake.
All righty. Thank you, Uba. Thank you, Dr. Raymond, for joining today. Let me, for sake of time, I do have I had 3 questions, but I'm gonna combine 2 of them. How much is data used? And it was great to see your presentation on using the data, because as one of my responsibilities, I have to present that data to our readers every day. How much of data goes into the daily operations of the college? And let me combine that with how much do you have to combat misinformation and bad data in day-to-day operations?
Yeah, thank you, Drake. For our external facing component of the Medical College of Wisconsin, we update the data every day, and we try to use publicly available third-party data sources from institutions that people would trust. Johns Hopkins, the New York Times has a really wonderful website, the Department of Health Services, the CDC. We try to use publicly available data sources. For internal use, we have a dashboard that we track that is pretty simple. We follow the case counts and the trajectory in Milwaukee County and for our regional campuses for the counties that they reside in. So it's not just the case count, but the direction that things are going. We also look at the percentage of infected individuals that are coming into our partner hospitals here in Milwaukee and also again at our regional campuses. When we see that there is over 2 or 3% of asymptomatic individuals that are testing positive when they come in the hospital, that's an indicator for us that we can't loosen up our restrictions. And then we look for the vaccination rate of our population and the internal spread that we may have within the 4 walls of MCW, which thankfully has been quite low since the beginning of the pandemic, because we've had very strict mitigation measures. In terms of misinformation, I think that is a real significant problem for all of us, and there are a lot of reasons for it. People have a mistrust of the government now, and unfortunately of experts. There is somewhat of an anti-science movement that has gained some traction, and there is a lot of data available, but people may not be trained to recognize whether data is accurate, has been well curated by a trusted source. And I would, certainly say that social media and the proliferation of immediately available data has compounded the problem. But I would also say that there are some trends in the mainstream media that haven't helped. For economic reasons, many media sources don't employ science writers anymore, or people that are trained to read scientific and clinical studies. with a critical eye and to make complex issues simple for the lay audience to understand. So we have a lot of work to do. And trying again to give simple messages that aren't overly simplified and then become politicized is a real challenge for us, Drake. And I would say, even today, I didn't acknowledge, and maybe I should, vaccines can and do cause significant side effects. And that would be something that a parent would consider. But what we know is you have to assess the relative risk of what happens with COVID-19 and what happens if you get a preventive like a vaccine. And the overwhelming risk-benefit ratio is in favor of getting vaccinated, even for kids.
Great. If I can just slide one quick question in. When you look at racial disparities in the health industry, how have you guys addressed that both with COVID and just long-term health disparities outside of COVID?
Yeah, thanks, Drake. I would hope, when we look back at the pandemic and say lessons learned, one of them should be that we absolutely, as a society, have an obligation to focus on the people that are disproportionately impacted by chronic disease and by the pandemic. So people of color in particular, in our region here, the African-American community, the Latinx community, and the Hmong community have been disproportionately impacted. In other parts of the state, Native American and indigenous populations have been disproportionately impacted in a negative way. And something that actually hasn't gotten, I think, enough coverage is isolated rural communities that are largely white also are suffering disproportionately from the impact and the burden of COVID-19. So a couple of things. One is we need to focus our attention on understanding the root causes. It isn't just healthcare access or quality of healthcare. The social determinants of health greatly impact people's ability to respond to a pandemic. Something as simple as being a single parent who's working multiple jobs with kids at home may not have the flexibility to be able to get vaccinated simply because of their work schedule. They may not have access to transportation that they need. They're living paycheck to paycheck and just can't afford to take time off. So those would be examples: safe and stable homes, living wage jobs, food deserts, all those things we really need to look into going forward. And then the behavioral and social aspects of the pandemic. I would single out the African-American and Black populations have historical mistrust of the government and of healthcare for good reasons, historical reasons, and that is a hurdle and a barrier that we need to overcome. What MCW and many organizations in the region have tried to do is acknowledge, first of all, that there's a problem, try to work with trusted faces, voices, and organizations in the communities that are disproportionately impacted by COVID-19 and to try to give good information to the best of our ability. And we have to craft our messages depending on who the audience is. The messages that will resonate in rural Wisconsin may not be the same as would resonate in Central City, Milwaukee. And our group here has worked with the MMAC, the Greater Milwaukee Committee, and the Ad Council to try to find effective ways to communicate. But again, just to get back, I hope that this is really a call to all of us to focus on health disparities, because first of all, it's the right thing to do. We're here to take care of everyone. And second of all, we can't have a vital economy and a thriving, vibrant community if we don't deal with the people that are disproportionately impacted by these health challenges.
Great. Thank you, Doctor. I'll turn it over to Rich.
Thanks. Hi, John.
Hey, Rich.
Thanks for doing this. You mentioned resuming normal life, and I attended a Brewers playoff game a few weeks ago with 43,000 other people, and fans are going to Bucks games. A lot of live entertainment has come back, and yet we're still doing stories about office reopenings. I asked Blake Moret, the CEO of Rockwell, today when they will be reopening their office, and he said soon. I said, what does that mean? He said months. So there are an increasing number of companies that are bringing back their employees, at least on a flexible basis, where they're maybe in the office 2 or 3 days a week. And of course, this is just for office workers, because people in factories and restaurants and hotels and hospitals and clinics have been on the job all along. But what's your suggestion or your advice for employers with office staff that have not brought them back yet, in terms of when and how to do that?
Well, every sector of the economy has different needs. And so we'll start there. And I believe most businesses in the community put the safety of their customers and their employees as a top priority. So I think what we do at MCW, again, is we track community spread. We look at our internal dashboard to make sure that we're not spreading COVID-19 within the four walls of the institution. And we have mitigation measures in place. And because we need to set an example, ours are probably stricter than many other businesses, and maybe stricter than they absolutely have to be. But I think months for a company that has a high density of on-site interactions probably makes sense. If you're able to bring people back into the office on a staggered basis, you may be able to bring people back sooner. And I think it's going to be a while before people are comfortable going back into the workplace without masks, although quite honestly, we are seeing that in retail settings where people interact with literally hundreds of folks every day, and they're comfortable going to work without masks. What I would say is it really matters what the burden of disease is in your community. We're still at a very high level in Wisconsin and even here in Milwaukee County. So some mitigation measures make sense. If we were down below 20 cases per 100,000 in the last 2 weeks, like we were in June of 2020, then you might say, you know what, you probably don't need to wear a mask in most settings, but we're not there right now.
And of course, the more maybe the biggest mitigation action that can be taken is a vaccine mandate. And some employers have reopened with a vaccine mandate, and others have reopened without one. Again, some of those are using masks and so forth. Where do you, obviously the medical college mandated vaccines for your faculty, staff, and students. But what do you think is the best practice for employers on that issue?
Well, again, it isn't my business to determine public policy or to tell people exactly what to do. There has to be some comfort level, but I'll just let the actions of the Medical College of Wisconsin speak for what our personal philosophy, my personal philosophy of leadership, and what we have here at MCW is we feel that we have an overwhelming obligation to protect the safety and well-being of our learners, our employees, and the people that come into our clinical care environment. So we really felt compelled that we had to mandate vaccinations. The federal government, depending on whether President Biden's recommended mandate is enforceable, is legal, is probably going to be the biggest single determining factor in whether employers across the board are going to mandate the vaccines. If you have 100 or more employees right now, the guidance is that you should be mandating vaccinations. And just in terms of where MCW is, Rich, we're at 99+% compliance. And what I mean by that, though, is we have 97% vaccinated. We have a little over 1% who have exemptions or are working 100% virtually and have chosen not to be vaccinated or are in process. November 1 was our date, and we've got a few people that are on leave of absence without pay while we determine what their status is. And we have had some resignations. This is probably the hardest part of vaccine mandates. You don't want to lose your workforce. We value our people, but we've had, and the numbers may be a little higher. This was as of last Friday, 54 resignations out of a workforce of over 6,000. And that's not including our residents. We've got about 1,000 in MICWA. And, you know, that's painful for us and difficult and hasn't been easy. But I also want to make sure everyone knows that the vast majority of our employees are behind having a mandate.
Okay, Uba.
Thank you, Rich. Dr. Raymond, my question is tailored around variants. When we think we've got got a lid on this thing, Delta emerges. How will people getting a booster shot, could they get a new variant if one does become relevant in the United States as we go into the last stretch of this year?
Yes, the simple answer is sure. Vaccinated and unvaccinated people can be infected. And if there's a new variant, there's the potential for everyone to get infected, whether you have a booster or not. But the risk of getting infected with the booster shots, at least thus far for the variants that have been detected, is dramatically reduced. There's a dramatic reduction in infection, a dramatic reduction in if you're infected to transmit to others, and a dramatic reduction in hospitalizations and death. I will just say we're in the area of speculation about whether there's going to be continuing emergence of more contagious variants. There's a school of thought that would say that the COVID-19 virus has mutated trillions of times, has tried to reinvent itself over and over again, and may have reached sort of the peak of its ability to infect people, because there's only a small stretch of amino acids that can be changed on that spike protein. On the other hand, I would say we shouldn't prematurely celebrate victory. We did that back in May when things looked great, and the CDC carefully said that people could take their masks off if they were with other vaccinated individuals inside the home setting. But what people heard, vaccinated or unvaccinated, we should take the masks off. So I do think that we're going to need to be careful. There could be an emergence of another more contagious or infectious virus, but I think the consensus is leaning towards that probably not happening, but we won't know till we know.
And I have one other question, if I may. We talked about, different color vials between the adults and the children, smaller doses. Are the side effects the same? If not, what could children be seeing once they do get vaccinated?
Yeah, thank you, Uba. Yes, the dose is less. It's 10 micrograms instead of 30 for the Pfizer vaccine, which is the one that we expect to be approved for kids 5 to 11. And the side effects generally are the same as they are in adults, the major ones: fever, headache, fatigue, sore arm. Those generally resolve within a day or two. What I would say, though, is each vaccine has its own side effect profile, which may be slightly different for kids than it is for adults. So the mRNA vaccines, the Moderna and Pfizer vaccines, can cause heart inflammation. That seems to be more prevalent in younger people than in adults. It's generally self-limited and resolves, although there have been hospitalizations and people with residual chest pain, and I think even one death from myocarditis. But again, it gets back to COVID-19 actually is more likely to cause heart inflammation, myocarditis or pericarditis than the vaccines. If Johnson & Johnson is approved for kids, we also have to consider that young women are more predisposed to have clots with either the Pfizer or the AstraZeneca vaccine. But again, we're talking about relatively rare side effects, but those still should be a consideration, even if they happen 1 in 10,000, 1 in 100, 1 in a million times. Those are considerations that the doctor and the parents are going to have to take into account. Thank you for the questions.
Thank you. Drake?
Dr. Raymond, can you talk about the experiences of medical students right now dealing with the pandemic and how that's changed the learning environment?
Thank you, Drake. Really interesting. First of all, our students are amazing, and they're flexible and resilient and curious and willing to do whatever it takes to learn how to be healthcare providers. And being in the middle of a pandemic that's unlike anything that we've had in over 100 years is a great learning opportunity for them and for us. We pivoted to virtual learning in the middle of March last year in less than a week, in part because we had been preparing for that since January of 2020 when we saw what was going on in China. The challenge for us, though, is for our students to academically progress, there are required clinical rotations that needed to be completed, and that otherwise they couldn't graduate and couldn't start their residencies. And early in the pandemic, students were excluded from the clinical care environment to preserve personal protective equipment, to keep the environment uncomplicated, and to reduce the risk of exposing them when we really didn't know that much about COVID-19. So we had to create clinically relevant virtual learning opportunities for our students that they actually like. They have done virtual nights on call. The technology allows that. It's been highly interactive, and we may actually do more of that going into the future. We expect we're going to have fewer students in real time in the classroom, which isn't any revelation. We've seen that across the board in education, and that students may choose to take their lessons asynchronously, in other words, when it's convenient for them rather than in real time. And so we do expect some of those changes to stick. What's going to be our limiting factor, though, are the accrediting bodies for our medical school and for residency programs are generally pretty slow to change. So I think the reality of COVID-19 sped up some of those changes.
Great. Thanks, Rich, or off to Rich.
Thanks, Rake.
Okay. Let's talk business, since I'm the Business Journal. I noticed that Froedtert and the Medical College announced a couple of weeks ago adding some physicians in Sheboygan, the Sheboygan area. And earlier this year, I think it's branded as Froedtert and Medical College moved into the Manitowoc market with Holy Family. So as I understand it, Froedtert drives that train more than you do in terms of the business decisions. But what are your thoughts? What's your perspective on Froedtert and the Medical College expanding into some new geographies to the north of Metro Milwaukee?
Well, from a business sense, if you're not growing, you're shrinking. What I would say is that we have an incredible talent base here that we would like to share more broadly across the state of Wisconsin. And we would like to do that in partnership with both Children's and Froedtert. And, we co-brand with Froedtert, and we share a health network. And we are focused on growing the business. And again, we think we've got a fantastic healthcare network and healthcare system, and just wonderful providers that we want to share across the state. So I would expect to see more, not less, in terms of partnerships and expanding our geographic footprint, both on the pediatric and on the adult side.
And speaking of Children's, also recently I did a story on Children's specialty group and Medical College extending their agreement by 30 years. So are you looking for growth on that front, both in terms of number of locations and geography?
We are, and we are very aligned with Children's Wisconsin in terms of our goal to provide the best care to all the kids of Wisconsin and beyond. But that market's different. Children's has a very dominant position. There really isn't the opportunity to grow that much. Most of the specialty care in the state actually comes to Children's Wisconsin. and there's a limited number of kids. We're not really growing our population. I think there's 1.2 million kids in Wisconsin, and we have strong competitors in Iowa, Minnesota, and Northern Illinois that would constrain the growth opportunities. So I think what our pediatric practice with CSG and Children's and MCW are trying to do is focus on efficient, high quality, easy access care for all the kids.
And of course, it's been growing with suburban locations, and there was the new location at Midtown Center a few years ago. Do you think there's more need, say, for city locations? Well, there's also one on the south side going in near Mitchell Street.
Yeah, Children's has a very focused strategy about how to grow where services are needed. And I would expect that, again, their philosophy is to provide care closer to home for the kids and to make it more convenient. So I would expect further expansion of those community-based opportunities for care.
All right, thanks. Uba.
Thanks, Rich.
All right, so Dr. Raymond, we've come a long way. We've got a long way to go, but is this new age group really, you said 28 or 29 million kids fit in that 5 to 11 years of age. Is this the age group that can really take us out the woods here?
That's a really good question, Uba. What I would say is vaccines only work when they're put in people's arms. And we have a lot of vaccines, but we really need more people to be vaccinated to reduce the community spread of COVID-19. And yes, again, anticipating people that are fans of natural immunity, you can get immunity from a COVID-19 infection. It's debatable about which is better, but I sure would rather be vaccinated than to have to take the risk of getting COVID-19 for myself or for my family or kids. So I do believe that if we can, every arm that we can get a shot in is a step closer to getting back to whatever the new normal is going to look like.
And my last question, if time wills, is, holidays around the corner, any concerns of a possible surge? Any thoughts on that?
I've heard people express concerns about a surge, and I think we do have to pay attention to what's happening in the UK. They had Delta 2 months before we did. They had a pretty quick upsurge, and it looked like they were trending in a favorable direction pretty quickly. And now they're struggling mightily, and they're more vaccinated than we are. So we do need to pay attention to that. On the other hand, I think if we have another surge, it's not going to be as significant as the one that we had just now, unless there's a new variant that emerges, and that it would likely happen in the late winter. I do expect to continue to see slow, steady progress with this current surge. But you've pointed out some of the variables. The weather's cold, we have more people going indoors, school has resumed, and we know that that has been a source of pretty significant outbreaks. People are returning to work, and of course the holidays, we're going to be gathering with family that may be from many different parts of the country. And so, those are just some things we need to think about. I'm planning to see my mother, but we're actually going to use the rapid antigen tests, and we're only going to have a small number of people that we interact with. Again, everybody has to make their own decision about what they're comfortable with. But for me, being able to get the Abbott rapid antigen test that you can buy for $23 for 2 tests, it is something that I'm able to afford. Again, it gets back to disparities, so not everybody could make that decision.
I'm gonna jump in here and say that if anybody in the audience has any questions, I don't see any yet, please kind of write them in the chat. Let me ask one quick, as you're just talking about this the whole idea of just getting more shots in the arm is kind of, Dr. Raymond, kind of why haven't we seen more? Kind of are you surprised at that? And kind of what needs to be done to encourage that? Or have we hit a plateau where it's just not going to increase?
Surprised maybe a little bit. I would say frustrated is a better word. It gets back to the pernicious and inaccurate, overblown memes about side effects of vaccines. And please understand, I acknowledge that that there are rare side effects that are severe, and people have to weigh that. The spread of poorly curated information, disinformation, misinformation, old information that is no longer current because science evolves, that people latch onto because it confirms their pre-existing beliefs. Mistrust of the government, mistrust of healthcare and health experts, an anti-science attitude, and the politicization of vaccinations. All of those have contributed to the hesitancy and the lack of confidence that we see here. And it unfortunately, again, this is my opinion, has made it more difficult for us to get to what we would call the new normal. And it's going to continue to be what I would say is a persistent and pernicious problem for us.
Is it kind of, when do you, I mean, if we continue on our current path, when would you expect us to hit the new normal? I mean, do you have an idea at this point? I know it's always hard to predict what's going on, but what are you thinking now?
Can I just add on really
Go
quick?
ahead, please.
It goes to my quick question that I was going to ask is this a pandemic or an epidemic? Is COVID with us to the end of time? Not to be so grim, but I think that's the broader question.
Well, it's unlikely that we'll extinguish COVID-19, so it'll become endemic. And many people believe that we're in the process of it becoming endemic. In other words, it's something that circulates and that we just have to live with. So I don't think that there's going to be a magic date when we say that transition happened or that we're in a new normal. Quite honestly, some people are in their new normal and maybe it's the same as their old normal. They're disbelievers in the significance of COVID-19 and they're going about business like they did before. There are others on the other extreme that may take a long time before they're comfortable shaking hands, going out to dinner, not wearing a mask. And I would predict that we're probably going to see a slow decline in COVID-19 over the next year. Again, the caveat being that we don't have another more contagious variant emerge that maybe escapes from immunity. But it's going to take us a year or two before everybody has gone on to their whatever we would call their new normal.
Interesting. Let me ask one question, kind of a follow up on Rich asked a question earlier about, we see, 25,000 at a Bucks game or 20,000 at a Bucks game. We see 40,000 at a Brewers game. We see 20,000 at a Summerfest concert. How do you react to that when we still have, obviously some people aren't in the office? I mean, kind of what is your feelings about these large gatherings, for the most part, which are unmasked?
I'm concerned, but look, I'm a scientist. So and I also recognize we're all tired. We're social animals and we want to go back to interacting with people. So I completely understand why people would want to do that. And I'm a big sports fan too. So I miss going to restaurants and seeing the Bucks and the Brewers. So I understand it. Let's see what happens. Let's see how much community spread is documented associated with these events and see how meaningful that is against the background that we already have. We know that music festivals resumed back in the summer and that there were significant transmissions that happened there when people were packed tightly together without masks on, shouting and celebrating in close quarters for a long period of time. But let's see what happens. I want to say Summerfest, what they did was very reasonable. Proof of vaccination or a negative test, and recommending that if people are going to be interacting closely with each other, that they wear masks. That was a very responsible thing to do. And you have a whole gradation of interactions where some places people are interacting freely without you knowing what the vaccination status or the test status is of other people, and those are obviously riskier.
I think when you look at Summerfest too, the attendance was down pretty low this year, and maybe people are turned away because of the pandemic. Do you think from an economic standpoint, we can afford to do that?
Probably not forever unless we change our economic model. So either we're going to have to get comfortable with mitigation measures, whatever they may be at the time, or or just accept that we have a different financial reality. I think this is a transition period, and that over time, people will be more comfortable going to these sporting events and music festivals and other gatherings than they are right now. And look at Big Ten football. Most of the stadiums are full now. And I think for the most part, that's been good. So there's no right answer, Drake, and I wish I could tell you exactly, but it is a strain. And I want to just say, Summerfest, the State Fair, really, really important events for our region. And we've gone a couple of years either with not having them or having lower attendance because of the things that we were doing. And that hurts our economy. But I think people want these events to be safe when they go back.
Interesting. And I mean, I guess I would end with just one question that you brought up there. Are you suggesting others kind of follow that lead in terms of restaurants and concerts in terms of the vaccine requirement? Is that something you'd like to see more of?
Well, it is a reasonable, from a public health perspective, those are reasonable measures that one could take, proof of vaccination or a recent COVID test. Probably not practical just because of how heavily politicized those interventions have become, how violent some people's reaction is in opposition, and how taxing that is for the frontline workers to have to be put in the middle of not just a public health issue, but a political issue. That's just really, really hard. And I don't think that there's any right answer. Every business has to decide what they're comfortable with, and their clientele and customers have to decide if they're comfortable with that as well.
Good. Well, we'll kind of with that, I'm going to end our questions. I want to thank our journalists. We've really had a great discussion here. Uba, Drake, and Rich. I really thank you for your help today and really for your questions. Dr. Raymond, again, you always provide great information. So, I mean, I really appreciate your time and your input. And I'm sure we'll see you probably this afternoon on a radio station, or hear you this afternoon on a station, or see you later this week on a TV station. So again, really thank you for all that you've done. Real quickly to end it, I want to promote our membership. We are currently in the renewal phase for next year for 2021 for the Press Club. So please, if you haven't renewed, please do. And if you want to join, obviously, please do. It's a great organization and one I'm proud to be part of. Just go on our website and just click on the membership area for that. Upcoming events, we will do a Meet the Media event in person on the 2nd of December at the Newsroom Pub. And we are planning our City of Milwaukee 176th birthday party at the Grain Exchange at the end of January. So again, I want to thank everybody today for your help and input, and just kind of wish everybody a great day. Thank you.
Thanks, Mark.
Thank you, Mark.